Hey all, welcome back to the Real Life Pharmacology podcast. I am your host, pharmacist Eric Christensen. Thank you all so much for listening. Today I'm going to cover Mirabegron. The brand name of this medication is Myrbetriq. And it is important to note that this medication at this time still is a brand name medication. So whenever you deal with patients that you need to use or want to use a brand name medication, you have to have the expectation that it's going to be very expensive, and in our medical system, it may or may not be covered by insurance initially. So that's always a big challenge, and I think a lot of healthcare professionals don't understand at least what the cash price for a lot of these medications are. So just to give you an example of Myrbetriq here as a brand name medication, the cost ballpark is in the range of $300 to $500 a month. And so that's substantially significant. And any patient that's taking this type of medication, that always has to be part of our assessment. So I just wanted to lay out that point because it is so important when it comes to patient adherence to recognize that cost plays a huge role. And depending upon that patient's insurance, how well they're able to afford that medication, they may be rationing it, they may be skipping days on purpose, they may be using that in a non-approved or inappropriate way that might make that medication less effective. So you just have to recognize when you're working with patients to ask those questions about the cost of medications and if they can afford medications. So getting over that little rant there, let's get into the pharmacology of the drug and actually how the drug works. So its classification, it is a beta-3 agonist. And you may remember beta receptors from thinking about beta blockers to other beta agonists. And the really important point about beta receptors is there's multiple subtypes of those receptors. So the three main subtypes of beta receptors where we have drug targets are beta 1, 2, and 3. So 1, those subtype of receptors are typically found in the heart, for example. Beta 2 are on the lungs, and beta 3, at least as far as drug targets go, are primarily found in the bladder urinary tract system. Now, mechanistically, how this drug works, that beta-3 receptor activation, or that agonist activity, it allows for the bladder smooth muscle to relax. And when that bladder smooth muscle relaxes, this allows for a greater capacity, greater ability to store urine. So this means that those muscles, they aren't constricting, they aren't contracting. And when you have that constriction and contraction, the patient, what they're going to experience likely is that sensation for going to the bathroom. So as you could imagine, this medication is used to manage overactive bladder symptoms, urge incontinence type symptoms. Now, I did mention the cost as being an important factor when it comes to reviewing and assessing patient adherence to medications. One other important factor is dosing. If you've got a medication that needs to be dosed multiple times per day, the more often you have to dose that medication, the more likely it is that patients are going to have a difficult time following that regimen. Now, with Mirabegron, it is an extended release product, and dosing is pretty easy, pretty straightforward. So we've either got 25 milligrams or 50 milligrams once a day. The one kind of major exception is there is an adjustment in patients with creatinine clearance, 15 to 30 mils per minute. Max recommended dose there is 25 milligrams. If we've got patients on dialysis, patients with creatinine clearance less than 15 mils per minute, it's recommended to avoid the use of this medication. One important point about that administration. So overactive bladder, urge incontinence, frequency, this is typically going to be a problem in your geriatric patient population for the most part. And it's important to remember that as we age, we may not be able to swallow medications quite as well as we used to. That may be an issue. I've definitely run into patients that are, crushing medications and mixing it in stuff. They're chewing up their pills actually in their mouth. And it's important to make sure we're assessing that as well, because something like Mirabegron, this is a medication that you're not supposed to split, chew, crush, because it is an extended release formulation. So be sure to assess that with patients that you might think have that borderline capacity or ability to be able to swallow a pill whole, for example. Adverse effect profile. So when I think about a drug that can act on beta receptors, we've always got this potential for working on some of those other beta receptors. So in the setting where a patient is maybe on the higher dose, for example, or for whatever reason, that beta-3 agonist is activating some of those beta-1 and beta-2 receptors. I specifically, as far as adverse effect profile goes, think more of the beta-1 activation. So beta-1 agonist activity, the potential ramifications from that are increase in blood pressure and increase in pulse. So it's important to recognize that Mirabegron, as a dose-dependent factor, may increase blood pressure and may increase heart rate. Okay, so very, very important to remember that. And when we go from that 25 milligrams up to that 50 milligrams, it's definitely going to be more likely to happen at that higher dose. So very important to recognize the pharmacology behind that, to understand the differences between beta 1, 2, and 3 receptors, and what blockade does versus agonist activity there. Another thing to keep in mind, if we kind of relax that bladder smooth muscle, sometimes these medications or Mirabegron is used in combination with other urinary anticholinergics. So keep an eye out for patients who may have urinary retention or be at risk for urinary retention. So if they have frequent stones, for example, that's probably a more rare case. More commonly, if they have something like BPH, that's going to block that bladder outlet, or potentially at least inhibit, reduce the potential for bladder outflow. And the drug, Mirabegron, in combination with anticholinergics as well, could potentially worsen that and worsen symptoms of urinary retention. So let's take a quick break from our sponsor here, and I'll finish up on drug interactions. If you're in the market for pharmacist board certification study material, we've got BCMTMS, we've got BCPS, BCACP, as well as BCGP study material. Definitely go check out meded101.com/store. We also have links to free audiobooks. If you've never had an audiobook from audible.com, they have a special promotion where you can absolutely get your first one for free. So I've got links there as well at meded101.com/store. We also have books on Amazon, Naplex study material, a whole host of clinical resources for nurse practitioners, med students, PA students, and all different types of healthcare professionals who have to understand what medications can do and how they can impact patients. So you can go check out those resources, help support the sponsor, help support our podcast. Go to meded101.com/store and check out all our resources there. With drug interactions, it's important to note that Mirabegron is a CYP2D6 inhibitor. Okay, so this is going to cause a lot of potential for drug interactions, particularly drugs that are impacted by alterations in the function of CYP2D6. So CYP2D6, it's an enzyme that breaks down certain drugs and or converts them into active metabolites. Now, the first three drug interactions I want to mention, so tamoxifen, tramadol, and codeine. These are all drugs that are actually activated by CYP2D6. So, if you use Mirabegron, if that's on board, and you start tamoxifen or you're using tamoxifen, Mirabegron, by inhibiting CYP2D6, is going to prevent the formation of the active metabolite of tamoxifen. What does that mean in layman's terms? You're going to have reduced effects from that tamoxifen. Now, obviously, tamoxifen being used in breast cancer, that's potentially a big problem. So you've got to be aware of that when we're thinking about using this medication. Tramadol and codeine. Codeine I don't see used terribly often anymore. Tramadol I do see a fair amount still. Those drugs also have active metabolites, and those active metabolites are created by the activity of CYP2D6. So again, Mirabegron on board, you're going to experience reduced analgesic effects from tramadol and codeine, or at least that's the potential. Now, it's dose dependent and may depend upon other medications and things of that nature too. But in general, that's likely what's going to happen. Now, we also have numerous drugs that are active that are broken down and turned into inactive drugs by CYP2D6. So with Mirabegron inhibiting CYP2D6, we can actually prolong the effects of certain drugs and increase the clinical effectiveness and or increase the risk of toxicity if we've got higher concentrations. So there are some classic psych medications in particular that are broken down, at least in part, by CYP2D6. Clozapine, an antipsychotic, aripiprazole, haloperidol, more antipsychotics. We've got a couple antidepressants, for example, fluoxetine, paroxetine. Those are also broken down by CYP2D6. So again, by using Mirabegron, we're more likely to have higher concentrations and increase risk of toxicity. One final drug interaction I want to wrap up with here is, in theory, the beta agonist activity, again, particularly maybe at higher doses of Mirabegron, that can oppose the effects of beta blockers. So your metoprolols, your propranolols, atenolols, and so on. In theory, that definitely could happen. So that is something that I would look out for. Again, we're going to probably monitor heart rate and monitor pulse to ensure that the medications are working effectively there. But again, when you give a beta agonist and the patient's on a beta blocker, if we've not hitting those receptor subtypes perfectly, there is some potential that effects could be blunted there. So I think that's going to wrap it up for today. I've got that free resource at reallifepharmacology.com. It's a 31-page PDF. I've had a lot of nursing students, pharmacy technician students, pharmacy students, and lots of other students, healthcare students who have to take pharmacology, take advantage of that resource. I really highlight super important stuff that you'll likely probably find on varying board exams, as well as pharmacology exams throughout college. So definitely go check that out, absolutely free for subscribing to the podcast, where we shoot you out emails when we've got a new podcast available there. So go check out that free resource. If you enjoy the podcast, if you find it beneficial, helpful, leave us a rating and review on iTunes or wherever you're listening. Also, shoot out an email to your class. We've grown exponentially because of your guys' support and sharing the podcast with your friends, with your classmates. Or if you're, a professor and you have students, definitely send them our way and give them a little extra education in addition to what they're getting in the classroom there. So I'm going to sign off for today. Thanks so much for listening. You can track me down on LinkedIn, as well as hit the contact button at reallifepharmacology.com. You can shoot me an email there if you have questions, suggestions, and all that good stuff. So Eric Christensen signing off. Thanks so much for listening. Take care and have a great rest of your day.